website. Good noon in Taiwan, good afternoon in Japan, and I think it's probably in the morning in Emirates, right? UAE Emirates. It's bad for you beginning at 8 o'clock in the morning. Anyway, well, I would like to take this opportunity to welcome everybody and joining this Asia Pacific Society of Cardiology Cloud webinar titled Risk Stratification and Tailored Management of Hypertrophic Cardiomyopathy, Evidence-Based Guideline. All right, this is a appropriate timing to do this. I am Dr. Stephen Huang. You know, everybody call me Stephen Huang. I've been in US for a number of years, and currently I'm Professor Emeritus of Medicine at Texas A&M University Health Science Center in Temple, Texas. But I live currently in the Los Angeles area, and welcome all of you if you had a chance coming to LA and to visit me. On a side talk, because some of you may be aware that I had an opportunity of working 6 years at National Taiwan University College of Medicine and Hospital in Taipei from 1996 to 2002. And I have since then known many colleagues, students, and friends in Taiwan, and I really miss them all. I would like to take this opportunity to thank Professor Lin Junli of Taiwan Heart Foundation and Taiwan Society of Cardiology for organizing this very important webinar and inviting me to participate as a chair. Now, it is my pleasure to introduce my co-chair, Dr. Jimmy Jyh-Ming. Okay, good, he is here, who is currently Professor of Medicine and Director of the Heart Failure Center in the Division of Cardiology at the National Taiwan University Hospital. He has profoundly devoted in genetic research of various arrhythmogenic disorders. As you all well know, that hypertrophic cardiomyopathy, with or without left ventricular outflow tract obstruction, is an autosomal dominant disorder, muscle disorder, with many kinds of clinical presentation outcomes. You may notice that in the most recent years, there have been more and more research pay attention to this disease. So to update this knowledge, it is the right timing to hold this webinar. And today we have a list of excellent speakers to give us a very nice reviews in various topics, including genetic confirmation of hypertrophic cardiomyopathy with the differential diagnosis of LVH, introduce some new randomized clinical trial of a new drug called mavacamten for specific medical therapy, and to discuss septal reduction therapy, surgical versus alcohol ablation, and to guide us for the risk stratification of sudden death and ICD implantation, and finally describe some stepwise management in patients with hypertrophic cardiomyopathy complicated with heart failure and life-threatening atrial and or ventricular tachyarrhythmia. So at this moment, I would like to make some announcement on disclaimer and housekeeping. As shown on this slide, the content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. The live streaming content of this webinar will be made available by APSC Cloud APSC Facebook and YouTube page. The sequence of our presentation today is, for each presentation will be 20 minutes of presentation, followed by 5 minutes of Q&A, question and answer period. So at this time, let me begin with Professor Chuang's interesting presentation titled Phenotype and Genotype Diagnosis of Hypertrophic Cardiomyopathy, and not all LVH are the same. Dr. Chuang, are you ready, please? Your microphone.
Please unmute your microphone. Dr. Huang, please stop sharing so that.
Oh, okay, got it.
Can I share my slide now?
Yes.
Okay. All right. Okay, did you guys see my slides and my voice is clear?
Yes, very good. Thank you.
Okay, and thank you for Chairman Professor Huang for kind introductions. It's my great honor to be co-chair with Professor Huang and the CEO of the great speaker online, especially in the COVID pandemic area. And my job for is also thanks for the APSC Asia Pacific Society of Cardiology for inviting me to give this talk. So today my talk is talk about the phenotype and genotype diagnosis hypertrophic cardiomyopathy. Not all LVH are the same. This is my disclosures. And as you know, this hypertrophic cardiomyopathy can cause cyclic cardiac death. And according to the previous status study published in Circulation in 2010, the commonest cause of sudden cardiac death in young competitive athletes in USA is the top one is hypertrophic cardiomyopathy, which is accounted for 1/3. So this is not common, really not rare disease, but especially in the young people. And what about the prevalence? According to previous study, the prevalence is quite to be varied. It could be the 1/500 to 5,000. Even the new study published, it may be higher. It could be higher 1/300. Depends because the new MEG like echoes, like MRIs, more advanced imaging resolutions can help us physicians to define the hypertrophy cardiomyopathy in the general populations. And this is quite common in adult cardiologists. In our clinic, it's quite rare in the children. This is because the hypertrophic cardiomyopathy is a genetic disease. And in the beginning of in the initial presentation, the genetic defect caused the hypertrophic cardiomyopathy, but it's not caused in the neonatal or in the children's area. It causes the heart dysfunction, and the hypertrophy goes up as you're getting older. This is why the reason is the prevalence is quite low in the pediatric department. It's quite common in our clinic. But so this disease, so as an adult cardiologist, we should pay more awareness on these patients. According to 2014 APSC guidelines, now what's the diagnosis criteria for hypertrophic cardiomyopathies? The guidelines say in adult, if the wall thickness greater or equal to 15 meters in one or more LV myocardial segment. This means in any segment, you don't have to have whole heart hypertrophy. Probably this hypertrophy is in just a segment area or in the apical areas, and greater than 50 millimeters, then you can say, oh, this patient has hypertrophic cardiomyopathy. But you should exclude some abnormal loading condition before you get this diagnosis, such as hypertension, exercise, like athlete, they have hypertrophy cardiomyopathy, but it's not pathological hypertrophic cardiomyopathy. It's physiological. But if the patient has a hypertrophic cardiomyopathy, their first relatives should be screening, but the criteria should be the wall thickening can be lower to 130 millimeters. So hypertrophic cardiomyopathy is defined by morphology, by the wall thickness, after you exclude the secondary causes conditions. And this is the image. You can see the hypertrophic cardiomyopathy, you can see quite whole. But I want to emphasize that hypertrophic cardiomyopathy is a morphology diagnosis, but it's not the final diagnosis because the many causes can cause the heart, the wall thick, but with different reasons. So this is a quite important slide for my talk. You can see hypertrophic cardiomyopathy, around 40 to 60% is caused by sarcomere protein mutations. That's what we learn from the medical school. It causes a myosin light chain, heavy chain, this is all these genes. But 20 to 30% were unknown. But this, this is why I said myosin binding protein C. This causes, we call this a sarcomere. So some people call it sarcomere hypertrophic cardiomyopathy. But another around 5 to 10% is also caused by genetic mutation too, but we call it lysosomal storage disease, such as Anderson Fabry disease is quite popular because some treatments come out in the past 10 years, and there has a good some study results showed if patients have Fabry disease, they treat earlier, they have good response. And this is also caused the heart to have hypertrophic cardiomyopathy. This is common disease. And the third disease of common disease is amyloid amyloidosis. Why I just said talk about these three diseases? This is because I think the treatment is the important things, because genetic disease, people always say, oh, I have some disease, but no cure. You cannot change anything. But for these three diseases, it's different because the Fabry disease has enzyme replacement treatment, and amyloidosis has a new treatment come out called diflunin, so I will mention about. So for us a cardiologist, when we see a patient has hypertrophic cardiomyopathy, it's quite important to figure out the underlying causes of hypertrophic cardiomyopathy. It's caused by sarcomere mutations, or it's caused by Fabry disease, lysosomal disease, or it's caused by amyloidosis. They will give the patient different treatment strategy. So this is different hypertrophic, different treatments. Regarding the sarcomere hypertrophic cardiomyopathy, the first, it was reported in 1958, the first report, but after around 30 years, the first gene was identified. It's called MYH7, but after a few years, another gene, MYBPC3 gene will come out. And more than 10 genes were identified in the past few years. And this slide shows you some summary of the slides quite common related to sarcomeric hypertrophic cardiomyopathy. And according to previous reports, up to 60% of patients with hypertrophic cardiomyopathy, the disease is dominant. So which means that if the father has the hypertrophic cardiomyopathy, the 50% of his kids can carry these mutations. And this I show you the idea of the gene dosage. So this animal study, if you conduct a knockout study on the mice, one gene mutation, the second gene mutations, if you put them together in the transcatheter study, it can cause more severe. So it's called double heterozygous cardiomyopathy models. And this is study in the families. The father and mother carry a mutation, and they has the kids. And both genes are put on, these kids had two mutations. So this case has early onset hypertrophic than his parents. So the current guidelines suggest that if a patient, identify a patient with hypertrophic cardiomyopathy, is class 1 recommended to perform genetic testing for patients and their families. But in this NGS eras, as you can see, there's more genes came out, so we can screen gene more efficient than before. So more genes are related or come out. So we have more in different areas. In the past, we don't have NGS. Now we have NGS in clinical practice. We can apply this genetic technology to help us to identify patients and to figure out the underlying causes and the guideline to a different treatment. So this is study published in 2018 years ago. This show the genotype and lifetime burden of disease of hypertrophic cardiomyopathy. So in this slide, it's about 400s. And this slide just give you some key message. The slide shows sarcomerial mutation is green lines here. And if you don't have sarcomerial mutation, but you do still have hypertrophic cardiomyopathy, you can see the green line and orange line is quite different. So in the overall composite endpoint, or in the ventricular arrhythmias, or in the heart failure, in the atrial fibrillation. So this is meant to give a key message is that if your patient has a hypertrophic cardiomyopathy, also they have the sarcomerial mutations, which has worse outcome than patient without sarcomerial mutation. So this gives us an idea. So genetic mutation can give some prediction about the prognosis of your patients. But when we do the genetic testing, we have to be very careful about the genetic diagnosis. This issue was published in NEJM a couple years ago. But this is what you talk about is some genetic reporting or previous report pathogenic, but after a couple of years, a new technology came out. So they found some common variant or classified pathogenic in white America, but not in Black Americans. So as the difference is quite important when you interpret genetic results in different populations. In Taiwan in 2020, we also conducted this study, and we enrolled more than 70 hospitals or medical centers, and more 170 cardiology referred patients or sent blood to my lab. So we actually call it SAS Taiwan Hypertrophic Registry. In our study, we also found that similar situations. Some previous reporting database called ClinVar database is report pathogenic variant in HCM, but we found this variant is quite high in Taiwan population, but all these patients were in control group. They do not have the hypertrophic cardiomyopathy, which means that this variant could not be called pathogenic in Taiwan populations. And vice versa, previously reported benign variant in ClinVar database in Caucasian populations, but it's quite low in our population. And so this, when you interpret a variant, you should be careful and should be careful about athletic difference. So for patients, we have to do genetic testing, but for how about their families? The guideline also shows as once you identify patient with hypertrophy, their first degree relatives should be screening, including their brothers, sisters, and their kids and their parents. That's kind of recommendation. But why we do that? So when you identify patient or their relative has the genetic mutations, if they are mutation negative, they are discharged. If they are mutation positive, even with or without clinical phenotype, they should be followed up. So this is an example shown to you in my clinic. That the patient came to my clinic with hypertrophic cardiomyopathy. They received ICD and even received alcohol ablations, had hypertrophic cardiomyopathy. Screen his son. I could show a little bit hypertrophy, but this young people has like exercise, practice all the time. So we could not different. This is hypertrophy caused by exercise or caused by, or he inherited the mutation from his fathers. So he performed genetic mutations for his father, identified mutations, MYBPC3, and also screening him. So he also carried this mutation. So we can say, oh, this patient has hypertrophy and it caused by inherited from his fathers. But his family history also tell his uncles had expired in quite young age and rule out acute myocardial infarctions. But we say these quite people, they don't have any risk, CAD risk, but they quite die young and suddenly at home. So we suggest them screen whole family. And then we identify some patient also have the hypertrophic cardiomyopathy, also carry these mutations. So genetic testing also can help the patient, help physician to diagnose your patients, also help family members and identify them earlier and give them some guidance. And this is single sequence performed in my lab. And so once we identify these MYBPC3 genes, some they will say, oh, okay, we given them beta block, we give some non-THP CCB, but new medication came out. The medication can inhibit MYBPC3 genes. And this is called Explore HCM. I think next speaker will give a very detailed about this trial. So I just give you some medications, new medication came out for your patients, especially for symptomatic obstructive hypertrophic cardiomyopathy. And this is medications called mevacatam. they can inhibit. This is the sarcomere, and it can inhibit here, and then try to reduce the hypercontractility, because the hypercontractility is the main problem in also in hypertrophic patients in impaired relaxations, and they also can help this. I think the next slide will give you the details. And this slide gives them this oral form. It gives them medications, and patient has a pressure gradient greater than 50s. And you can see after patient added this is the new medications, the functional classes improve a lot, from lower around 20% to 30 to 50%. The pressure gradient also decreased too. So you can see this is a placebo group. This is a patient taking mevacatin. The pressure gradient decreased a lot, and the response rate increased to 30%. Another new message I want to share with you is the patient, the metoprolol. They conduct a randomized clinical trial and published in last year. In this year, they show it the beta block can also decrease the heart rate contractility, increase the diastolic filling, decrease the OT, the pressure gradients. The patient, the symptom can decrease, the life quality can increase. They can do more exercise. So although they could not change the maximum exercise capacity, but the beta block is quite efficacious, can improve patient quality of life. So this is the first slide, sarcomere mutation. Next, we'll go through a little bit about the next, around 10 to 20% is the Fabry disease. As you can see, the Fabry disease is caused by the alpha galactosidase A mutations. This gene defect can decrease the alpha A activity. It can decrease, then you can undetectable. So this enzyme is quite important, because this enzyme is very important to clear some, we call it the glycoGB3. This is enzyme. But once you have deficiency or you don't have this enzyme, this is a GLB3. This is repeatedly accumulated in the lysosome. So the normal lysosome is in this size, but if once you lose, you have mutation, you don't have alpha A enzyme, or enzyme activity is quite low, the lysosome will increase in size. So GL3 will filter in the lysosome. So once this lysosome accumulated in all your bodies, in your eyes, or in your heart, or in your kidney, or in your skin, they will cause difference. They will cause a Fabry disease. But one disease is a classic Fabry disease. It can involve multiple systems, but the other some special variant, we call it genetic variant. This is a Fabry disease. It just called LAP3 GB3 accumulate in the heart main predominantly. So in this GB3 deposit in CV systems, then the patient will hypertrophy, cardiomyocytes, then it also cause the inflammation, ischemia, hypertrophy, fibrosis. And once this system will destroy it, it can cause a short PI interval arrhythmia, heart failure, and even cause the syncope, sudden cardiac death. And this is cardio variant. This is the staining, the tubular staining. You can see this is some abundant granular accumulation in here, and electron microscopy, you can see enlarged. You can see enlarged lysosome here. You can see we call it the zebra body. So some people they just have there's a Fabry disease, but it's called just involve the heart. They have the normal nervous system, normal kidneys, normal eyes, and etc. So, but we call it cardio variants, quite common in the Fabry disease, and also onset late in the life. This case give you some idea. 59 patients referred to my clinic in 2008, and it was diagnosed with LVH 10 years ago when he has a health checkup, and later on, every year he has cardiac arrest during treadmills and receive CPCR IC implantations. And I asked him the family history. He said he has a young brother died just a couple of years ago. So we see, oh, this is probably a genetic cardiomyopathy. So we do a plasma test. You can see the plasma lyso-GB3 is quite higher and the activity is lower. And we screen his family, and we also say, oh, this is some young sudden cardiac death in his family. So there's increase our awareness of this probably is not simple, the acidic athlete hypertrophic cardiomyopathy caused by genetics. And also he has a brother also have hypertrophy. So I think all this is quite like dominant. So as you can see, this is probably a sarcomere mutation, or it's probably it can cause by the amyloidosis or Fabry disease, because you can see all the males. The probably is as a link Fabry disease. And this is his ECG after ICD implantations. So we can do echo for him. You can see there's a septance quite thickening 2.4, and the pressure gradient is not much. It's not greater than 50s. The MRI also shows it's higher. And we do some the cardiac biopsy. You can see laminar body, mimic like zebra body. So Fabry disease is favored. We do genetic testing. We find a mutation in GL1 genes. But we also to have a comprehensive hypertrophic cardiomyopathy screen testing. So we also perform the TC99 PYP muscle scan, but it's negative. So this just means this case is not ATTR cardiomyopathies. And this is the patient's brothers. You can see the strong T inversion, and you can see a little bit like delta wave here. And we also perform the echo, and it has hypertrophy in the septance. And we also MRI show maximal thickness 2.4 meters. And the plasma lysoGPC is increased too. And with genetic testing, biopsy also suggests he has Fabry disease. And this is single mutation performed in my lab. So we can confirm this patient has a Fabry disease, and as well as his brothers also have. Most of them are receiving the standard cardiology treatment like beta block or CCB, but the most important, they are receiving enzyme replacement treatment. It's quite main treatment for this Fabry disease now. And then next, the final one I talk about will be the amyloidosis. Amyloidosis, you can see the protein misfolding disease. It can accumulate in whole body, even in the corner of the bone. So misfolding protein causes this amyloidosis. The main type of cardiomyopathies can divide by two major types. The first one is immunoglobulin light chain amyloidosis, and the other one is transthyretin amyloidosis. The both types account for 95% of all cardiomyopathies diagnoses. So it's quite important. And a long time ago, there's no treatment for ATTR. We just have a treatment for light chain amyloidosis, and both can cause hypertrophy. So once with the patient diagnosed with cardiomyopathies and it's a light chain, we refer to hematologist or give them some treatment for them. But now we are cardiologists, some things to do because there's ATTRs coming out. And the prevalence it's not really very high, but it's higher than light chain amyloidosis coming out of cardiomyopathies, because ATTR is quite common. It can occur in the old people, in the young people as well. And so the transthyretin cardiomyopathies, this because our liver can produce transthyretin ourselves. It's normally, but once you have genetic mutation, this protein became unstable, so it can become a tetramer. So this will be folding and it become monomer. So this monomer transthyretin accumulate in whole everywhere in your heart, including heart everywhere in your body. It also causes carpal tunnel syndromes. So the two types, subtype of ATTR mutation, this is called mutant type or wild type. And both types should be defined by genetic mutation in TTR gene. And the inhibitory is also dominant. So it's the same, it's like the sarcomere mutations. Patient has sarcomere mutation, it's also dominant. And patient has cardiomyopathies, is also dominant, which means that have 50% that can inherit their mutated gene to their kids. So the family should be screening tools and to identify who has a mutant ATTR, who has a wild type. So the wild type has been quite old, and the difference between two types is age. The mutant type can become earlier, it can vary from 30 years to 80 years. The wild type usually occurs in the 70 or 90 years old. We saw some people call it snail systemic amyloidosis. So it can involve nervous system, also cause dysneurology, cardiac hypertrophy, eyes. And this is a slide showing the summary difference between hereditary or wild type cardiomyopathies. The different mutation has different type. but most important thing is that it's autosomal dominant. So you refer the case to my clinic, and I just go, oh, this is site 59, no underlying hypertension presented display insertion, paralytic epictic edema, corneal cough, and he was a hypertrophy many years ago, and doctor just gave him the beta blocker ACI for years, but symptoms did not improve. And then he feel normally is stiffening bilateral hands for years. So you can, oh, this is quite different. Patient have some cardiac symptom, but also have some atrial symptom too. So this caused my attention. So I maybe probably genetic testing, and also has a father. His father also died in the park when he was 65, but it's hard to say it's caused by cardiac CAD or AMI, or it's caused by hypertrophic cardiomyopathies. And this is life for this patient. So you can see that the voltage is not much poor aware progressions, a little bit slow voltage in his heart. And with screening, comprehensive screening February disease, we do some immunofluorescence. We do not find any monoclonal antibody, so which means we can exclude light chain cardiac amyloidosis. So this is a cardiac echo. You can see hypertrophy. We do some nerve study. We found that sensory motor polyneuropathy in axon degenerations. So this involves 3 systems. The patient have hypertrophy, also involved the nerve system, also 2 systems. So we arrange the cardiac MRI. We see a delay enhanced by ventricular myocardians. And we also arrange the TC99 PYP muscle scan. We can see the enhancement here. So we can see, oh, this is a typical ATTR cardiomyopathy. Then we perform genetic testing in our hospitals. We confirm this patient has ATTR mutants. So this is a ATTR cardiomyopathy mutant type hypertrophic cardiomyopathies. And new medication has come out. So this is called tafamidis. So tafamidis is a new medication, is published just in 2019. So a patient has cardiomyopathy only, or even they have cardiomyopathy with neuropathy treatment, they can receive tafamidis. The study shows there's a great improvement for patients' heart failure, the mortality improve a lot. So this patient now, they have opened a new window for their treatment. So this is my final slide, key message. The cardiomyopathy is inheritable and complex phenotype and genotype disorders. So most important thing for us, especially for general cardiologists, is early to identify the cause of genetic cardiomyopathy is very important for us, because you have because that different genetic cardiomyopathy has different treatments, and especially has some genetic cardiomyopathy has some new treatment. Like we said, cardiomyosin inhibitor, FABC enzyme replacement, or tafamidis for cardiomyopathy, and some new trials are still going on. So I can expect more treatment will come out in the coming few years. And finally, besides treating our patients very well, don't forget their family members, because they are most of them are autosomal dominant inheritable. So early identify family members who are at risk, but even they are clinical symptomatic, is quite important, because they can tell them you can come to clinical regular follow-up. Once they have some treatment, we can give some suggestion. Thank you for audience and for speakers. Thank you so much.
All right. Hi. Maybe you want to come up your slideshow. Hi. Now it's open for questions from anybody, either from speaker or from any participant on the website. Any questions? Any questions? No? Okay, Dr. Juang.
Yes.
Professor, I will start a question first.
Yeah, sure, Professor.
Okay. Well, sounds like hypertrophic cardiomyopathy is kind of a broad spectrum of the sarcomere disease. In fact, what we have encountered clinically, hypertrophic cardiomyopathy, probably more or less on the first type 1, rather than Fabry or amyloid, which is, to me, is kind of rare. Maybe not that rare, but at least compared to the traditional hypertrophic cardiomyopathy with the myosin disorder. So my question directed to, why some type of hypertrophic cardiomyopathy usually only involve the left ventricle and not the right ventricle, except the amyloidosis. And also, either hypertrophic cardiomyopathy, I mean the traditional definition, or the Fabry disease that show high voltage on ECG, correct? But on amyloidosis, in the severe form, in fact, it causes low voltage because infiltration of the myocardium. So do you think there is some differences because of genetic mutation that cause involvement LV and RV? Is my first question, and also involvement on the ECG changes?
Yes, thank you, Professor Fang, for excellent questions. This is quite, Professor always asks very tough questions.
Oh no, I don't know.
Yes, yeah. So regarding the first questions about the question why the genetics just involve the left ventricle, not right ventricles. In fact, according to the whole study, hypertrophy, around 10% to 15%, they can involve biventricular hypertrophy.
Okay.
Yeah, but why we do not see hypertrophy in the right ventricles? First is the right ventricle it's very thin naturally.
Mm-hmm.
Now it's compared to left ventricle. So in the normal heart, right ventricle is very thin. There's a very few myocardial cells over there. So compared to left ventricles. So you can see the septum is quite hypertrophy, left ventricle hypertrophy, but right ventricles, they have some, we can say that have fewer cardiomyocytes in the right ventricle.
Usually by echocardiogram or MRI or whatever, it's pretty normal, except that I've seen amyloidosis involve RV quite often.
Yeah, so once I think why this is not involved, I think probably two reasons. If you're a geneticist, it's supposed to be to affect both ventricles, right? But first thing is imaging. So imaging detect rays using echo screening, people always focus on the left ventricles. For right ventricle, the windows, it's not quite good, it's not good. So the probably under diagnosis, that's a reason. So in academic studies, they also show that 10 or 15% can involve biventrically. But so I can see now the cardiac MRI that has a very advanced technology now. So I can see regarding the resolutions, detecting rays. If people screen using the more advanced cardiac or cardiac MRI, I think we can see more patient has left ventricle as well as right ventricles, probably under diagnosis.
Well, I think it's quite interesting because, this hypertrophy part is more or less involving the left ventricle, but then something arrhythmogenic dysplasia, something like that, involve a lot of ventricular tachycardia that involve the RV more, but recently, of course, also involve LV, but it kind of vice versa. One predominant in LV, one type of genetic disorder involve RV. I'm not so sure because RV also have myosin. Why not RV also get involved? See, this is a question always puzzle me. Okay.
I think I do not have a clear answer for this.
All right, good.
Because this is so gap between the genetic mutations and the phenotype. So because the genetic mutation rate for some people is still 30% to 40%. They do have the hypertrophic cardiomyopathy, but we could not find the gene. I think this is an area that we're still working on. But why some gene behavior is different in right ventricle and left ventricle? Some reason, some people say kinetics, left ventricle and right ventricle kinetics are different. So this is the gene. That's probably the trigger factors.
Okay. Well, because of time constraint, I'm not so sure. One question from anybody or from speakers on the panel? Any questions? Well, Dr. Juang, it's excellent presentation. I do have some other questions, but I can ask you privately through email, okay?
Okay.
I cannot ask you a lot of questions because I'm quite interested in genetic disorder anyway, so it's really intriguing me. So why don't you introduce the next speaker?
Okay, so next speaker, I think it's very quite important. The Dr. Rodney Jimenez. Dr. Jimenez is currently is an assistant professor. He's from the University of East Raymond Megasaya Memorial Medical Centers. He also the head of resuscitation service at St. Luke Medical Center, Quincy City and Global City, Manila, Philippines. So today we were very happy to have Dr. Jimenez. He's going to give a talk entitled of evidence-based medical treatment for obstructive hypertrophic cardiomyopathy, starting from Explore HCM clinical trial of melocatin. Let's welcome Dr. Jimenez.
Yeah, thank you very much, Professor Huang, Professor Stephen, Professor Jimmy. Let me share my slides. Okay. Oh, what happened? Is it visible? Oh my God. Is it visible now?
Yeah, very good. Thank you.
Okay, thank you very much. Good afternoon. Thank you again for the invitation to speak to in the APSC Cloud webinar. I was asked to talk about the evidence-based medical therapy for obstructive hypertrophic cardiomyopathy and, of course, explore HCM, a clinical trial of Mavacam 10. I am Dr. Rodney Jimenez, representing the Philippine Heart Association and Philippine College of Cardiology. So hypertrophic cardiomyopathy, as discussed a while ago, is a disease of hypercontractility characterized by the thickening or hypertrophy and impaired relaxation of the left ventricle. It is estimated to affect 1:500 people, and it is the most common heritable form of cardiomyopathy. So about 2/3 of patients have the obstructive form of disease, in which the thickening of the left ventricle results in a dynamic obstruction of the ventricular outflow tract. But current medical management for obstructive HCM does not address the underlying cause of disease, and these options may sometimes be inadequate or sometimes poorly tolerated. Symptoms, including those of heart failure and chest pain, are all due to combination of diastolic dysfunction, left ventricular outflow obstruction, mitral regurgitation, and small vessel ischemia due to microvascular dysfunction. The purpose of pharmacologic therapy is to reduce the pressure gradient across the LV outflow tract by reducing the inotropic state of the left ventricle, improving thereby compliance of the left ventricle, and thereby reducing diastolic dysfunction. Beta blockers have been the mainstay for 5 decades, and they reduce the inotropic state of the left ventricle, and they decrease diastolic dysfunction and increase LV compliance, thereby reducing the pressure gradient across LV outflow tract, and they also decrease heart rate, thus lowering myocardial oxygen consumption and reduce potential for myocardial ischemia. And beta blockers are most effective for exercise-induced. It is also effective but less so for resting obstruction. Beta blockers do not have the potential risk for associated with vasodilator, which may decrease afterload and which may be harmful in patients with significant outflow tract obstruction. One of the pieces of evidence is a cohort study of 27 patients without resting LVOT obstruction, but an exercise-provoked LVOT gradient of 30 millimeter mercury or greater. Treatment with beta blockers for 1 year resulted in significantly lower post-exercise LVOT gradients, about 36 millimeter versus 87 millimeter mercury at baseline. This double-blind placebo-controlled randomized crossover trial enrolled 29 patients with obstructive HCM and NIHA score or New York Heart Association functional class 2 or higher symptoms from May 2018 to September 20. And they found out that compared with placebo, metoprolol reduced LVOT obstruction at rest and during exercise, provided symptom relief and improved quality of life in patients with obstructive HCM. And maximum exercise capacity remained unchanged. An alternative to beta blockers are the 9-dihydropyridine calcium channel blockers, particularly the verapamil. It decreases the inotropic state of the LV also. It decreases the gradient across the LV also outflow tract. And it decreases diastolic dysfunction and increases the diastolic filling of the left ventricle by improving LV diastolic relaxation. One of the pieces of evidence is a cohort of 55 patients treated with verapamil, oral verapamil with 360 to 640 milligrams per day for 1 to 4 weeks. 35 or 64% reported an improvement in symptoms. Symptomatic improvement correlated with improvements in diastolic feeling, and this benefit persisted for 1 to 2 years and was reversed when therapy was discontinued. Verapamil is tolerated well in most patients. However, it may be associated with a variety of side effects, including sinus arrest, AV block, and pulmonary edema in patients with markedly elevated pulmonary venous pressures. Now, let's go to disopyramide. Disopyramide is an antiarrhythmic drug with negative inotropic properties, more powerful than beta blockers and verapamil in controlling LV outflow tract obstruction. In the case of refractory symptoms despite beta blockers or calcium channel blocker therapy, an add-on strategy with disopyramide is recommended. It is the only drug that has been shown to lower resting LVOT gradients in HCM, and it decreases ventricular arrhythmia and supraventricular arrhythmias. The drug decreases diastolic dysfunction also and increases LV compliance, thereby reducing the pressure gradient across the LV outflow tract. So here I randomized double-blind crossover study compared the effects of disopyramide 150 milligrams 4 times daily and propranolol 40 milligrams 4 times daily and placebo, each given for a period of 4 days. With that, the subaortic pressure gradient decreased from 61% with placebo to 5 millimeter mercury with disopyramide and 30 millimeter mercury with propranolol. And disopyramide also increased the exercise duration while propranolol produced no significant change. In a prospective single-center cohort of 737 patients with HCM, including 299 patients with LVOT obstruction and symptoms despite therapy with a beta blocker or verapamil, disopyramide with a mean dose of 501 milligrams per day was added as a second medical therapy in 221 patients. And there was an adequate control or improvement to avoid invasive septal reduction therapy in 141 patients. And the addition of disopyramide also significantly lowered the resting LVOT gradient from 61 millimeter mercury to 10 millimeter mercury. The limitations of disopyramide include it can accelerate AV nodal conduction, resulting in an increased ventricular rate of atrial fibrillation or flutter. Thus, patients treated with disopyramide should also be treated with beta blockers. Like any other class 1A antiarrhythmic drugs, disopyramide can prolong the QT interval, possibly leading to torsade de pointe. That's why disopyramide has traditionally been started in the hospital setting to monitor for prolongation of the QT interval and arrhythmias. Now, for patients with HCM who have persistent symptoms of heart failure and LVOT obstruction despite monotherapy with a beta blocker or non-dihydropyridine calcium channel with verapamil, it is suggested that combination therapy with initial agent and a negative inotropic agents, option combination therapy include beta blocker and disopyramide, non-dihydropyridine calcium channel blocker or verapamil and disopyramide, and beta blocker and non-dihydropyridine calcium channel. It is preferred that the beta blocker and disopyramide as the most efficacious dual therapy for treating heart failure due to LVOT obstruction. And with this approach, lower dosing of AV nodal agent is feasible. And when using calcium channel blockers and verapamil together, this approach is frequently limited with symptomatic bradycardia. This is the ACCF-AHA treatment algorithm for non-obstructive HCM. May not be part of my discussion, but I'll just show you anyway, so as to compare with the treatment of the obstructive hypertrophic cardiomyopathy. So this non-obstructive, if you don't have heart failure symptoms, then you just check the patient clinically annually for evaluation. And if you have heart failure symptoms or angina, check for the LV systolic function. If the LV systolic function is less than 50% ejection fraction, then you may follow the guideline of the heart failure with reduced ejection fraction. Now, if you have patients with more than 50% or more than 50% of ejection fraction, you can use beta blockade or verapamil. And if the patient is congested, you can use diuretic cautiously and ACE inhibitor and ARB cautiously. It's a class 2A. Now, let's go to the obstructive physiology. Now, obstructive physiology, if we have obstructive hypertrophic cardiomyopathy, then avoid vasodilator therapy and high dose diuretics. Now, if you don't have any heart failure symptoms, then you just evaluate the patient clinically annually. And if the patient has symptoms, then you use, as we have discussed, the beta blockade and verapamil, and sometimes in combination with disopyramide. But even when optimized, this regimen fails to address the core pathophysiology of the disease and does not seem to affect its natural history. Thus, novel advances in the medical treatment of obstructive hypertrophic cardiomyopathy are eagerly awaited. So we will discuss, as discussed a while ago, the pathology of HCM is that it has too many cross bridges between actin and myosin, which produces excess work and makes it harder for the muscle to relax. Now, this mavacamten is a selective allosteric inhibitor of cardiac myosin ATPase, and therefore it reduces the number of actin-myosin cross bridges, and it improves how the heart relaxes. It reduces how hard it works to pump, and reduces how much energy it uses for each heartbeat. This study, the Explore HCM, was a phase 3 double-blind placebo-controlled multi-center trial done in 13 countries. It was designed to assess the efficacy and safety of mavacamten in adults with symptomatic obstructive hypertrophic cardiomyopathy. It enrolled patients with LVOT gradient of 50 or more millimeter mercury and the New York Heart Association class 2 to 3 symptoms, and they received mavacamten or placebo for 30 weeks at 68 sites. 97% of the population completed the study. And the primary endpoint was composite of functional endpoint designed to specifically demonstrate benefit in symptoms using the NIHA class and function using the peak VO2 or the peak oxygen uptake measured by cardiopulmonary exercise testing. So it's either 1.5 mil per kilogram per minute increase in the peak VO2 with one or more NIHA class improvement, or just a 3 milliliter per kilogram minute of increase in peak oxygen uptake with no worsening of the NIHA class symptom. Secondary endpoints assess in changes in post-exercise LVOT gradient, peak VO2, NIHA classification, improvement, and patient-reported outcomes such as the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score and the HCM Shortness of Breath Subscore questionnaire. The cohort was 251 patients, the largest of the HCM study ever tested, with 123 randomized to mavacamten and 128 randomized to placebo. The trial was very successful. Mavacamten treated led to highly statistically significant improvements in all study endpoints compared to placebo after 30 weeks. 37% achieved the primary endpoints, doubling those in the placebo. Okay. With regard to the secondary endpoints, it showed that patients on mavacamten exercised more, were less symptomatic, had greater relief in obstruction, and had greater and felt better. No? This is evident with the questionnaires in the KCCQ and the HCMSQ questionnaires. The number needed to treat targeting the primary endpoint was also small at 6, and even smaller in the secondary endpoints. Very recently, in the Explorer HCM cardiac magnetic resonance sub-study, mavacamten treated was shown to induce reverse cardiac modeling on mavacamten presented a greater reduction in the LV or the LV atrial volume index, reflecting hemodynamic improvement and the decrease in LV filling pressure. And this structure changes parallel reduction in the circulating biomarkers. This is a possible treatment algorithm for obstructive hypertrophic cardiomyopathy therapy proposed by Algiro after the mavacamten study. So if you are symptomatic obstructive HCM, you use first the beta blockers, or if there's a contraindication and it's not tolerated, then use the dihydropyridine calcium channel blockers or verapamil. And if the symptoms persist, you can combine it with disopyramide. And if symptoms persist, also you can switch to myosin inhibitor or mavacamten, or probably directly combine it with the beta blocker or calcium channel blocker. And if symptom persists, if the patient is candidate for surgical myomectomy, then do so. And if it's not, then you can do septal ablation. In March 2021, the US FDA accepted the new drug application for mavacamten, an investigation novel oral medication for patients with symptomatic obstructive cardiomyopathy. So in summary, hypertrophic cardiomyopathy is a genetic heart disease characterized by various degrees of left ventricular hypertrophy, hyperdynamic contractility, and mitral valve abnormalities that may lead to LVOT obstruction. LVOT obstruction is the main cause of the disabling symptoms and heart failure in HCM patient. It is relieved, and its relief is a fundamental therapeutic aim requiring concerted effort by physicians and surgeons. For patients who have symptoms of heart failure and LVOT obstruction, it's recommended that initial monotherapy be started with the negative inotropic agents such as the beta blocker or calcium channel blocker. Because of the known safety profile and lower likelihood of peripheral vasodilation, it is recommended using a beta blocker as the initial choice. Now, if symptom persists, combination therapy with disopyramide is the next step. And experts generally prefer beta blocker and disopyramide as the most efficacious dual therapy for treating heart failure symptoms due to LVOT obstruction. Mavacamten is the first drug developed to target the underlying molecular defect of hypertrophic cardiomyopathy. Explorer-HCM was the most comprehensive and adequately powered randomized clinical trial conducted to date in HCM. And in the Explorer-HCM trial, treatment with mavacamten improved symptoms, exercise capacity, and key aspects of health status in patients with obstructive hypertrophic cardiomyopathy. And we hope that this will help improve the lives of many patients with hypertrophic cardiomyopathy. Thank you very much for that kind attention. I think I was on time.
Yes, thank you, Dr. Jimenez, for excellent talk to go through the Explore trial and treatments. So is there any question from the audience?
I'd just like to comment also that disopyramide and mavacamten is not yet available in our country.
Oh, yeah.
Oh, is that right?
Yeah,
Disopyramide?
we're only limited with the beta blockers and verapamil, unfortunately.
Well, I tell you, it's all available in the US, but in Taiwan, it was available. It's called NoPace, but I think the pharmaceutical company, they don't want to import due to the low profit.
It's
So,
probably the
the
same reason in the Philippines, because they only see so very few patients.
I think this drug is still not yet approved by FDA in the US. And I'm not so sure it's been approved in Europe. Do you know Europe? I know it's not been approved in the US yet, but it just accept application from Bristol Myers, but has not approved. So far, as far as I know, has not approved on this mavacamten. But I'm not so sure it's been approved in the Europe, because usually they are approved first in the Europe.
Yes. Yeah, well, I haven't seen any news yet on the mavacamten in the Europe. So it's only in the US FDA the acceptance of the new drug was I've seen the
sounds a very nice medication because it works specifically on beta myosin. So it's a great medication. It may be also treatable in the patient with heart failure. For example, with a bad failure, but I'm not sure for heart failure, say New Heart 4. And that degree, I'm not sure, but I think a 2 to 3 heart failure is okay to use this medication, which is contraindicated for most of other medications.
Yeah, the Explorer only tested it in patients with NIHA 2 to 3.
Right.
So,
all the clinical trial avoid class 4 heart failure, right?
Yeah. I don't know if this is also the mavacamten will also affect amyloidosis effect. Is it the same? I don't know.
No, it's different.
Yeah,
it's quite different medication. Yeah,
quite different. For cardiac amyloidosis, it's called diflunisal. Tafamidis. It's called tafamidis.
Tafamidis. Yeah.
Oh, diflunisal. 2 medications.
Yeah. Okay.
Tafamidis is a new one.
I got it.
More effective than diflunisal.
Not many people know about this medication.
Yeah, I know. I do not know that.
We still have something to do in the future.
Right. Well, that's very important that the research been toward the right direction anyway. It's more molecular based and genetic based, target, oriented therapy, which is nice. All right, maybe it's okay with Dr. Juang. It's
yes. So if
yeah.
there's no question, well, thanks so much for Dr. Jimenez for excellent talk. Then we'll move to next speakers.
Okay, I will introduce the next speaker, Dr. Bassam Al-Baba. He is, hi.
Hi.
Okay, we haven't seen you on the screen yet. Okay,
Yes,
camera, here you go,
here.
hi. I want to say hello to you. I miss you a lot. Okay, great. Well, thanks for joining us. Good morning, by the way. Okay, he is a consultant of cardiology and interventional cardiology in our Hcm Hospital and wait a minute, Sharjah, right? Sharjah? Is that pronounced Sharjah?
Sharjah.
Oh, Sharjah. Okay, Sharjah.
Ministry of Health.
Okay, got it. I'm sorry. I apologize for mispronounce it. From the United Arab Emirates. Okay, Bassam, would you please go start?
Yes. Hello, everyone. Thank you for sharing me in this informative and comprehensive session. My talk today is about what is the best for treating symptomatic obstructive hypertrophic cardiomyopathy. Is it myectomy or alcohol ablation? Really, there is debate about this, which is the better. This is my outline. And as you know, that hypertrophic cardiomyopathy is a common disease and is the most frequent cause of sudden cardiac death in people aged less than 40, especially in athletes. Diagnosis, to confirm the diagnosis of hypertrophic cardiomyopathy established by imaging, especially by 2D echo or sometimes by TE, or few times we need help of cardiac MRI because the view or the result from the echo is not enough to diagnose the Hokkam. And we need thickness to be more or equal to 15 millimeters anywhere in the left ventricle in the absence of another cause of hypertrophy in adult to diagnose. But in some peoples, we accept to be more than 13 millimeter for diagnostic purposes, especially in patients with family history of Hokkam or in patients with positive genetic test. This is how we confirm the diagnosis. As we mentioned before, this is summary of what I mentioned before. Left ventricle outer tract obstruction, either at rest or by provocation, is present in about 75% of all cases of Hokkam. As you know, we have multiple morphologic variants in Hokkam, but 75% of all are considered as LV outer tract obstructive. And you know, as my friends mentioned before, that the obstruction is dynamic and sensitive to ventricular load and contractility, and increased myocardial contractility or decreased preload or lower afterload will increase the gradient across the outflow of the ventricle. And if we compare cases with obstruction with non-obstruction, as you can see here from this meta-analysis, that the mortality is higher in significant way in group of obstruction, as you can see here early. And we need gradient to be more or equal to 30 millimeter to consider that there is obstruction. But for significant obstruction, we need resting or provoked gradient to be 50 millimeter or more. For symptomatic patient, in spite of my colleague mentioned to the medication, and still the patient symptomatic, so this patient could be referred for septum reduced therapy, which is abbreviation is SRT, septal reduction therapy. So what is our approach to obstructive Hokkam? We start with lifestyle modification, pharmacotherapy, then we go to the invasive treatment, either for septum reduction therapy, either with surgical myectomy, or versus alcohol septal ablation. This is the recommendation from the guideline 2014. Now we have another guideline which is released from the ACC, American College of Cardiology, at 2020, and here you can recognize that the indication of septal reduction therapy, that the patient should have a gradient more than 50 or more, with still in NIHA class 3 or 4, despite tolerated medical therapy. And septal myectomy, rather than alcoholic ablation, is recommended in patients with either lesions requiring surgical intervention, like mitral valve repair or replacement, or papillary muscle intervention. And which is very, very important and recommended as one recommendation, that this procedure should be performed by experienced operator in the context of comprehensive clinical program and only for the treatment of eligible patients with severe drug refractory symptoms and with obstruction. It is not indicated at all to be done if there is no significant obstruction. So, regarding septal surgical septal myectomy, relieves obstruction by direct removal of septal muscle. In addition, that abnormality of the valve and papillary muscle can be addressed at the time of the septal myectomy, and which is very important during surgery to optimizing the result, to use TEE, transesophageal echo, during surgery. And also, before leaving the theater, we have to also do provocation test for some case to optimize our surgical therapy. Maybe there is remaining tissue should be removed, and the rest gradient is normal, but by provocation there is still significant gradient required more tissue removal. So myectomy is the gold standard because it is induced symptom and gradient improvement immediately and consistent and permanent. Also, valve and coronary artery disease in the context of surgery could be managed. It requires a skillful surgeon and there is low risk, particularly in younger, and less need for permanent pacemaker. And also, we can take biopsy during the surgery, and we can sometimes change our diagnosis according to the pathology result. Maybe the diagnosis is incorrect. Maybe the patient have Fabry disease. Maybe this is another amyloidosis. So this is an example how symptom reduction done by surgeon, and you can compare between the left and right how reduction of the symptom and the obstruction induced by this kind of surgery. And this kind of surgery really it is safe, and the mortality and I will start with the conduction abnormalities according to this meta-analysis, which is released in 2016 and recruit a huge number of patients, that the number of complete heart block, the percentage, it is less than 1%. It is 0.6 in patient with without pre-procedures any conduction defect. But if the patient have right bundle branch block before, the percentage of developing complete heart block during the procedure, the myectomy is very 35%, but in total in this meta-analysis, if we take all the patients together, the percentage it was 2.4. So you can recognize here if patient with right bundle branch block before myectomy, the incidence of developing complete heart block, it reached to 35%. And using contemporary surgical method during aortic valve approach, it now with this result, the mortality is less. Now it is 1% or less. And from this released in 2000 study about Mayo Clinic experience in 2020, this study, and you can recognize here that the 30-day mortality, it is 0 in 298 consecutive patients did myectomy. And also the long-term survival is encouraging, and it is high. It is after 5 years, it is 96%. And after 10 years, it is 83%. And if you compare it with patient with, it is comparable to the patient with non-obstructive hypertrophic cardiomyopathy, and it is also comparable to the general population. So, here you can also recognize in this meta-analysis, which is published in 2019, that the complete heart block developed in only 1.1% post-myectomy, and the operative mortality, it was minimal. It is 0.38%. What about VSD? In few cases, if the symptom is not large, sometimes in a few cases, which is the percentage is less than 0.5%, patient may develop VSD. But nowadays, by guiding the surgery by TEE, the incidence it will be reduced and really it reduced significantly by doing the surgery guided by TE. So this is the myectomy data from Mayo Clinic from 2000 to 2015. Operative mortality, it is 0.4, significant gradient reduction, and NIHA improved significantly post-surgery. So I will summarize when to consider surgery. Yes, first in young age, if there is thickening of the septum more than 3 centimeter, or if it is intrinsic significant valvular disease or membrane, significant coronary artery disease, and amenable to BCI, or if there is baseline left bundle branch block, and mid-cavity obstruction, and we need, as I mentioned before, large institution experience with excellent surgical outcome. I will move now to the transcatheter septal ablation in Hokkam. The same indication as I mentioned before, symptomatic patient with NIHA 3 to 4, and or there is recurrent syncopal syncope on exertion with significant obstruction to be more or equal to 50 at rest or with provocation, and we need proper left ventricular morphology, suggesting that the septal thinning abolishes obstruction, septum thickness to be 15 millimeter or more, and no other cardiac disease requiring surgery like mitral valve disease or any other disease. And alcohol septal ablation relieve obstruction by creating localized myocardial infarction at the area of obstruction. And you can see here, this is the first septal. Sometimes we deal with the first or the second septal. Sometimes and we inject alcohol to induce infarction at the site of obstruction. This is the technique, which is very simple, but there is some instruction the operator should be follows this instruction to avoid any catastrophic complication, especially dissection in the coronary artery, and which is more risky is spill out of the alcohol into coronary, which is catastrophic really complication may happen if the operator deflate the balloon earlier. So this procedure should be guided by contrast enhancement, myocardial contrast enhancement to recognize where is the obstruction and which is the septal supplying this hypertrophied area which is responsible for instruction. And by using this contrast guided by contrast enhancement, this will increase the success first, and other, it lower the rate of complete heart block, which may follow this procedure. And before, if there is MR, mitral regurg, we have to recognize if it is MR related to the SAM, systolic anterior motion, so we can proceed with alcohol ablation. But if it is due to the primary mitral regurg, primary etiology, so you cannot proceed. If it is moderate or more, we have to go with myectomy to correct the mitral valve regurg in the context of the surgical myectomy. So what is really, this technique is safe, and the mortality according to this Euro registry, that the mortality is 1%, but pacemaker dependence, we need to insert permanent pacemaker to 12% of the patient, which if compared with myectomy, it is significantly higher here. And also, if we go with this meta-analysis, which published in 2018, we can recognize that the mortality is very few, but the permanent pacemaker required in more than 10%, and during follow-up, 17.2 patients underwent re-ablation due to the planned staged procedures, and 2% underwent surgical myectomy during follow-up, which is this percentage also much higher if we compare with surgical result. Also, this procedure is safe regarding long-term survival. We can recognize here that the long-term survival is comparable to background population. And which is important, don't use extra alcohol during the procedure. And you can recognize from this study, which recruit a huge number of patients, that if we use more than 2.5 ml, that the mortality is very much high. It is 11.3, which is not acceptable. So it is important to use as the recommended dose, which is about 2 ml for ablation, alcoholic ablation. Others, that if the septum is more than 25 millimeter in thickness, the survival is significantly less if we compare with if it is more or less than 25. And in this study, which recruit a huge number of patients and published in 2020, we can here appreciate that we can recognize here that the mortality is significantly higher if the thickness of the septums is more than 30 compared with less than 30. So in conclusion, this is safe procedures. More in-hospital mortality is low, and it is comparable to the surgical myectomy from the data coming from a Cleveland Clinic and from Toronto General Hospital, which is less 1%. But alcohol septal ablation, when performed in experienced centers, may be considered when sometimes we give a priority to the myectomy, but sometimes we have to respect the patient preference during the multidisciplinary discussion and informative discussion about what is the benefit and what is the negative regarding case by case. And we have also to realize that if the thickness, if more than 30 millimeter, we have to avoid alcohol ablation and to go for surgery. And if we summarize here, when we have to consider alcohol septal ablation in advanced age, if there is significant comorbidity, patient previously implanted pacemaker or ICD, a previous open heart surgery, prior stroke, and ideal anatomy for alcohol ablation, and if there is baseline right bundle branch block. As I mentioned before, if there is baseline right bundle branch block, and we did myectomy, the incidence of complete heart block, permanent, requiring permanent pacemaker, it is very high, as I mentioned before. So, and we need a large institutional experience with excellent outcome regarding this. So, if this is the last part for comparison between septal ablation and myectomy, you can realize here that the mortality is comparable, but regarding the permanent pacemaker, it is significantly higher when we go with alcoholic septal ablation, and the need of re-intervention during follow-up, it is also significantly, in significant way, it is higher when with alcohol septal ablation. Here you can recognize that there is no difference regarding sudden cardiac death, but as I mentioned before, alcoholic ablation had a higher incidence of post-procedure device implantation. This is meta-analysis also comparing the two procedures, and here you can recognize in this study that the re-intervention, it is significantly higher in the alcohol group, septal, but the mortality, it is the same. And if you go to the data coming from Mayo Clinic from 1973 till 2016, you can recognize that the number of myectomy is enlarged in significant way compared with static number of alcoholic ablation. I will go for the latest guideline in a few slides for 2020 of American College and the American Heart Association. The same should be done with experienced hand in experience center, comprehensive or primary for Hokkam, which is mandatory, should be done. If your center is not like this, you have to refer your patient to another center which have more experience of this dedicated procedures. For patient with Hokkam undergoing surgical intraoperative, as I mentioned, guided by TE, the procedure, it is mandatory to achieve excellent result. Also should be guided by T, transthoracic echo or TE for patient undergoing alcoholic septal ablation, and should be guided by enhancing contrast also. And again, all this mentions that in symptomatic patient with obstructive Hokkam, if it is another anatomy requiring surgery, it will be done during the surgery, including if the patient have atrial fibrillation, we can fix it during surgery by intracardiac ablation or by Okay. So at the end of the story, we have to mention that in patient with, we can do surgery sometimes earlier with NIHA 2 surgical if it is done by comprehensive Hokkam centers, and especially if there is another something else which puts the patient in high risk if there is like severe pulmonary hypertension. Yani I summarize, if the patient still not class 3, still in class 2, but there is severe pulmonary hypertension, surgery may be considered if it is done by expertise in comprehensive center. So this is the advantage of septal myectomy, the same as mentioned before, and this is the advantage again for septal myectomy, as I mentioned before. Even if there is atrial fibrillation, it is better permanent atrial to go with surgery. We can do ablation during surgery or maze procedures to fix the atrial fibrillation. Advantage of alcoholic septal ablation, we avoid sternoctomy and cardiopulmonary bypass and their associated risk, avoiding surgery for patients with comorbidity to do surgery. Also in the case of complete right bundle branch block, it is better to go with alcoholic ablation, and also hospital stay and recovery time is less when septal ablation. I conclude with my opinion is surgical myectomy is still the gold standard for hypertrophic cardiomyopathy. Even I am interventional cardiology, and I did my first case of alcoholic ablation at 2021, but I did in my life a few cases, but I am convinced that surgical myectomy is the gold standard for hypertrophic cardiomyopathy in most of the cases, with a few exceptions. As I take home message, more complete
Dr.
myectomy.
Obama,
I finished.
The time is over. So
Yes, I finished.
Yeah.
This is the last slide. More complete and predictable relief of gradient and symptoms, low mortality and low risk for permanent pacemaker. Thank you. Sorry for some delay.
All right, thank you. Thank you, Dr. Obama, for his very detailed discussion about the myomectomy and or surgical reduction therapy. I think this is a very broad topic, a lot to discuss about it, and you have done a lot of detailed discussion. I wonder, I don't think we have time for questions. We are really run out of time. It's okay, Dr. Lin, if we're running out of time? I think we may have to move.
No problem. Yeah, it's okay.
It's okay?
We can talk about
all right,
5 to 10 minutes.
I see one audience actually is Dr. Juang, Professor Juang raised a question. He asked about, for a patient who has mid-ventricular septal obstruction, which way is better to do, surgical or versus alcohol? I think you just answered the question at the very
second. Absolutely myectomy in this case. Absolutely.
Right. Yeah, I saw you listed on the second last slide. The surgical myectomy is preferred in patients with a mid-septal obstruction. So that
because in this part of the heart, the septum is small. There is no large septal in this area, and you cannot manipulate in a small septum to induce a large infarction. Really, it is what we did during alcoholic. It is large infarction, and may it reach to 10% of the myocardium in total.
Great. Well, I think for those patients who had concurrent mitral regurg,
yes,
sometimes if you want to do alcohol ablation, you may want to combine with the percutaneous mitral clip
Yes,
to correct
this
the
is an option.
MR. Yeah, that's also
This is an option.
non-surgical. Yeah, yeah.
Thank you for this
for
comment.
those patients who underwent surgical myectomy, I think just go ahead and do surgical,
especially
or replacement. Yeah,
I agree totally, especially for patients with comorbidity to surgery. This is an option to do alcoholic, then to go with mitral clip. Yes, I agree totally.
Thank you. Great. Well, a great talk. We all learned a lot from you. Thank you so much. Okay. Now we move on to the next speaker, Dr. Juang.
Okay.
Professor Juang. Yeah.
So, okay, we move to next speaker. Next speaker will invite Professor Yasushi Oginosawa. Professor Oginosawa is from the second department internal medicine, the University of Occupational Environmental Health in Fukuoka, Japan. He's going to talk about the sudden cardiac death risk stratification for hypertrophic cardiomyopathy in adults. Time for ICD prophylaxis. Professor Okinawa, please.
Thank you, Professor. Hello, everyone. My name is Yasushi Oginosawa from Japan. I'm very honored to have this opportunity to have a presentation in this great session. So let me share my slide. Can you see my presentation slide?
Yes.
Okay.
It's very clear.
Now, the topic of this presentation is sudden cardiac death risk stratification for HCM patients in adults, the timing of ICD prophylaxis. This is my COI. Today, there are three things I'd like to talk about. The first one is sudden cardiac death of HCM and the effect of ICD prophylaxis. The second one is risk stratification and indication of ICD. And the last one is the timing of ICD implantation. So let's start with the first one. There are three main causes of death in HCM patients. Sudden death, heart failure, and stroke. This is before ICD were commonly implanted prophylactically in HCM patients. About half of the deaths were sudden cardiac death. This is a graph showing the relationship between age and HCM-related cause of death. It shows that heart failure deaths are common in all age groups. Stroke is common in elderly, and sudden cardiac death is common in relatively young age groups. In a study reported 2000, 368 patients with HCM between the age of 14 to 65 years who were followed for average 3.6 years, 22 patients, about 6% died of sudden cardiac death. The following is a brief history of ICD and HCM. ICD, developed in 1980, were initially implanted as a secondary prevention because of the large size of the device and the need for abdominal implantation. In 1988, transvenous ICD became available, which were implanted as primary prevention, mainly in patients with low cardiac function and high risk for ischemic heart disease without a history of cardiac arrest or VTVF. In 2000, ICD began to be implanted in patients with HCM, and several criteria for indications for prophylactic implantation in patients with HCM have since been established. The result of 70 years follow-up of 2,094 patients in whom the need for an ICD was determined according to the criteria in the guidelines shows that 82 patients who had an ICD implanted were aborted by the ICD therapy, while only 5 patients who did not have an ICD developed sudden cardiac death. Therefore, ICD are a dramatic therapeutic tool to prevent sudden cardiac death. However, ICD have not only medical complications such as infection, lead fracture, or inappropriate shock, but also social problems such as driving restriction in Japan or occupational issue, as well as medical cost. Therefore, the question of to whom and when should ICD be implanted is extremely important. So next, I would like to talk about risk stratification and indication of ICD. Who should be implanted with an ICD? In the 2003 ACC ESC expert consensus, cardiac arrest, spontaneous VT, family history of sudden death, unexplained syncope, and LV thickness more than 30 millimeter, abnormal blood pressure response during exercise, and non-sustained VT were listed as major risk factors for sudden cardiac death in HCM patients. Following that, the logic of ICD implantation for high-risk patients with these risk factors was present. So, how many risk factors can be considered to high risk? Early study from European physicians have shown that the more risk factors there are, the higher the risk of sudden cardiac death. On the other hand, another study reported from United States found no difference between patients with multiple risk factors and those with only one, and appropriate activation of their ICD, with 35% of ICD interventions occurring in those with only one risk factor. Since then, the guidelines in the United States and Europe have become very different. The 2011 ACC/HA guideline for primary prevention indicates that a patient with family history of sudden death, marked left ventricular hypertrophy, or recent unexplained syncope, ICD is reasonable. For patients with non-sustained VT or abnormal blood pressure response and other risk modifiers, ICD can be useful. In contrast, ESC guidelines use a mathematical model to calculate the 5-year risk of sudden cardiac death and suggest a policy of primary prevention with ICD in high risk. A patient with an estimated incidence of sudden cardiac death of 6% or more over 5 years, ICD should be considered. And 4% to 6%, ICD may be considered. How about our country? In Japan, 2 guidelines for ICDs in HCM patients have been published. Because these guidelines are almost same, I'd like to spot the first one. In Japanese guideline, the ESC 2014 guideline risk models is used as a major risk factor, along with many classical risk factors, and LVOT obstruction, late gadolinium enhancement on cardiac MRI imaging, dilated phase HCM, and ventricular aneurysm are used as risk modifiers. Regarding the new risk marker, LGE on CMR, it has been shown that the event-free survival curve of the group with no LGE and LGE less than 5% is good, while the group with LGE more than 5% is at extremely high risk of sudden cardiac death. In addition, patients with left ventricular aneurysm have been shown to have significantly more arrhythmic events than those without. The following is a chart of Japanese guideline. At least one of major risk factors, such as syncope, marked LV hypertrophy, or the risk model of the ESC guideline considered as class 2A indication. Several other risk factors, such as family history of sudden death, non-sustained VT, and abnormal blood pressure during exercise, is also considered as class 2A indication. Furthermore, one of these major risk factors and present risk modifiers, the patient eligible class 2A indication. The United States guideline focus on each risk factor individually, while the European guideline use a risk model. In contrast, the Japanese guideline takes both into account. Therefore, Japanese guideline can be said to be intermediate between ESC and ACC/HA guideline. On the other hand, when ESC model is applied to past these reports, the low sensitivity of ESC risk model, more than 6% over 5 years, the mean sensitivity was only 33%. This indicated that the occurrence of sudden cardiac death due to underestimation is a concern. The latest HACC guideline published in 2020, ESC risk model was not adopted again. LGE and apical aneurysm were upgraded to major risk factor, and abnormal blood pressure response disappeared. At least one of the following risk factors, ICD is class 2A indication. Non-sustained VT or LGE on cardiac MRI, ICD may be considered as 2B indication. A validation of these ICD criteria was reported from China recently. The higher rating by the ESC guideline risk model, the more events occurred, but actual events were significantly higher than those predicted by the risk model. In contrast, the 2020 HA-ACC guideline shows that patients with no risk factors had a very low incidence of sudden cardiac death, while patients with at least one risk factor had a significantly higher incidence of sudden cardiac death. So, HA-ACC guideline 2020 also showed better ROC curve compared to the others, and area under curve was 0.71. So, when is it appropriate to implant an ICD? This is not an easy question to answer. While only 11% of patients has their first appropriate ICD intervention within a year, the highest percentage of patients, 36% had their first intervention more than 10 years after ICD implantation. In addition, there were similar cases of intervention during that time. On the other hand, the time between unexplained syncope and the first clinical evaluation, especially patient under 18 years old, is less than 6 months, indicate a high risk of sudden death. Thus, occurrence of unexplained syncope may be an alert that predicts sudden death event in the near future. However, it should be noticed that relationship between syncope and the time to sudden cardiac death is not necessarily well established marker in adult over age of 18. This is a flow chart of the clinical evaluation of ICD implantation for primary prevention that Dr. Maron presented last year in Heart Rhythm Journal. In patients with at least one major risk factor, ICD implantation is recommended, while patients without risk factors should be evaluated repeatedly, at least once a year. So this is the conclusion. ICD substantially reduce sudden cardiac death in high-risk patients with HCM. In addition to classical risk factors, new factors such as LGE in cardiac MRI or apical aneurysm and probability assessment using mathematical risk models have been presented for the indication of primary ICD prophylaxis. The timing of the onset of fatal arrhythmia is difficult to predict. Continuous observation and re-evaluation is necessary, even in patients who are no longer eligible for ICD implantation. Thank you for attention.
Okay, Dr. Chuang, you go ahead.
I thank you, Professor Oginosawa, for excellent talk. Sorry, I did not turn on my microphone. So I do not see any question from the audience.
I do.
You do?
I sent you 2 questions.
Oh, I did not get it from the message.
Uh-oh. Okay, let me repeat. I sent you and it was sent. Okay. My first question is, in fact, is for Dr. Chuang, but something related to ICD prophylaxis or high sudden risk stratification. Do you think, is there any specific genetic mutation that you have mentioned about on your first talk that will really give us a clue that such patient with such gene mutation really has the highest risk for sudden death?
Okay. And thank you, Professor Wang, pointing out these important issues. So far, there's no specific mutation that can predict future sudden cardiac death in patients with hypertrophic cardiomyopathy.
Oh,
no large clinical trial or cohorts to show that, but some small study in the previous 10 years ago, they do they can compare the difference between A gene or B gene, which one is good, which one is better, compare different. For example, like MYBPC3, that was not good. MYHT7, this one not good either, compared to the other one. So for now, for genetics, people just divide into sarcomeric mutation versus non-sarcomeric mutation, 2 groups. Sarcomeric mutation included many genes, so we one group. So in the published in Circulation in 2020, they found that people with a sarcomeric mutation, they have worse outcome, including heart failure, atrial fibrillation-related stroke, hospitalization. So sarcomeric mutation can predict that, but not single gene.
Right. Yeah, exactly. But you know, because what I was told or heard about from Dr. Oginosawa, that there are no specific risk factor that was included that contains a genetic disorder. So I think in the future, perhaps somebody like Professor Juang, you may want to, if you have a large population, you may want to find out which specific gene really is responsible for high risk. I think that's important. For example, in patients who had unexplained syncope, for example, and who had a positive family history, and now you want to discuss with patient, hey, you should put a prophylactic ICD. And then I'm sure genetic study is necessary. Now for that particular first degree, the family, if he was found positive and specific for something, you know, sarcomeric mutation of a specific gene, and you say, oh, see, you are really at the high risk group of genes. So I would really suggest you should put a prophylactic ICD. You know, that's something come out of my my brain. I'm not so sure that's useful. But the second question I have that's more specific for ICD is, do you think, Dr. Oginosawa,
Yes.
what type of ICD would you recommend? You know, you put on ICD in general, but there are many subtypes of patients presentation. What type of ICD, say, is a dual chamber ICD or combined with the CRT or something else, you know, with the pacing that the pacing will have to be programmed into always pacing with short PR interval. Although pacemaker has been controversial, been probably abandoned, but still, I wonder what kind of patient would you recommend put a CRT and CRT with a defibrillation, or just by chamber pacemaker, dual chamber?
Thank you. Great question. I think dual chamber pacing may be useful for great LV obstruction patient.
Mm-hmm.
If there's no obstruction, I think the dual chamber pacing ICD is not needed.
Mm-hmm.
It's only single chamber is okay. And another choice is subcutaneous ICD.
Yes.
Mm-hmm.
Sometimes difficult because of the screening of the ECG. But it may be a good choice for especially young patients because the longevity of ICD lead is concerned. Of course, a patient with low LVEF and left bundle branch block, based on the HCM, it's CRT-D is useful for these patients.
Sure.
Yeah.
I think in the future, I think it's still in the early infancy that there is something coming up that D-less ICD. So I think if that comes, that will be very interesting. D-less. Okay, that is fairly new. Just come up. Okay, just in the research. All right. Well, okay, I have no further questions.
Okay. So is there no question? We'll move to the next talk.
Okay. Next talk, I'll be. It's my pleasure to introduce Dr. Vichai Senthong, who is associate professor in the Faculty of Medicine, Khon Kaen University from Khon Kaen, Thailand. He's going to talk about this is a very important last talk, tailored management for hypertrophic cardiomyopathy, complicated with heart failure, with reduced or preserved EF, and atrial and/or ventricular tachyarrhythmia, kind of a multidisciplinary heart team approach. It's a sum up of our talk today. So Dr. Vichai Senthong, please.
Good afternoon from Thailand. Dear Chairman, Co-Chairman, ladies and gentlemen. On behalf of Heart Association of Thailand under Royal Patronage, I'm really glad to be here, and I would like to thank APSC for inviting me. Here is my disclosure. Let me start with this case. This is a real case that we will see in our clinic. the young man, 37 years old, with obesity, hypertension, and sleep apnea, present with occasional leg edema and dyspnea on exertion for 4 weeks. He has no syncope or palpitation, and negative family history for sudden death or diagnosis of hypertrophic cardiomyopathy or Hcm. On examination, show obesity and a little high office blood pressure. We heard systolic ejection murmur without the change during Valsalva or standing, and of course, pitting edema. On the ECG, you can see that the left ventricular hypertrophy, the GFR around 62. On chest X-ray, it's questionable about, not sure about congestion, which is common in obesity patients. So on echo, you can see the concentric wall thickness. The maximum thickness is around 24 without LVOT gradient or without obstruction. The LA size around 71. And interesting, NT-proBNP is 2,200, which is quite high. For this patient, I have 2 questions. The first question, does the patient have heart failure, preserved ejection fraction, or HFpEF? And how to confirm diagnosis? And importantly, in second question, what is the etiology for heart failure in this patient? It may be from hypertensive heart disease or hypertrophic cardiomyopathy or Hcm. Let me show the data. Well, the diagnosis of HFpEF is still challenging because it's quite heterogeneity on criteria diagnosis. Depend on the caregiver to use the criteria. So recently, an updated ESC heart failure guideline according to the diagnosis criteria for HFpEF. Patients should have sign and symptom of heart failure with ejection fraction above 50. However, the sign and symptom in HFpEF patient with is non-specific because a lot of patients will be present with unexplained dyspnea. Second criteria, the natriuretic peptide. However, around 30% of HFpEF, the natriuretic peptide will be normal, especially in obesity, same as our patient. And the echo criteria like structural abnormality and functional abnormality. And again, around half of patients with HFpEF, the functional, echo functional, I mean, the LV filling pressure will be normal at rest and will be abnormal or elevate only exercise. Therefore, this criteria do not discriminate well between HFpEF with other clinical conditions. However, for the statement of heart failure of Europe, suggests to use diagnosis algorithm that call HFA-PEF. I will call heart failure PEP. I will call HFpEF diagnosis algorithm. The algorithm like a stepwise approach. Step 1, looking for pre-test probability, looking at the clinical evaluation and standard echo. If this step had an intermediate to high probability, we go through step 2 using heart failure PEP score by a comprehensive echo. If the score is low, yes, we can cut the patient not HFpEF. If the score is high, we can confirm HFpEF. However, if the score is the gray zone on the intermediate, we go through step 3. Step 3, we should use an exercise stress echo that I mentioned previously. Around half of the patient with HFpEF, the echo at rest will be normal. And after that, after we confirm HFpEF, do not forget to step 4 to final etiology. What is the exactly cause of HFpEF for this patient? This is heart failure PEP score using the comprehensive echo and biomarker, have 3 domain, major and minor criteria. If score at least 5, 5 and above, we can confirm diagnosis of HFpEF. Is the score less than or equal 1, we can rule out HFpEF. However, if its score is in the middle, around 2 to 4 points, we should take the next step to exercise stress echo. Well, do not forget in the final step to final etiology. Should looking for blood pressure control, chronotropic incompetence, ischemic workup is negative. We can initiate like standard treatment for HFpEF. And importantly, if we questionable about cardiomyopathy, we should use advanced imaging, especially cardiac MRI, biopsy, or genetic testing that Dr. Juang mentioned in the previous session, especially in patients with amyloidosis or Hcm. Again, if negative, we can initiate standard treatment for HFpEF. Back up to our case. Our case had signs and symptoms of heart failure. Looking at echo, positive both functional and structural abnormality. E per E prime is 17.95. Evidence of increased LV filling pressure. And NT-proBNP is quite high, around 2000. So we calculate heart failure PEP score is 6. We can confirm HFpEF. And again, do not forget the final step to final etiology workup to differentiate between hypertensive heart disease or Hcm. Well, that Dr. Huang mentioned previously, the criteria diagnosis of Hcm depend on the wall thickness, family member, or genetic testing. Importantly, without secondary cause. For now, I think it's still challenging to distinguishing between Hcm and athlete heart and LVH due to hypertension. To differentiate between Hcm and athlete heart, if we favor Hcm, the wall thickness above 15 and LV cavity is small, positive family member, and importantly, cardiac CMR, cardiac MRI show late gadolinium enhancement, especially in the mid wall or the insertion zone of the right ventricle. If we favor the athlete heart, the LV wall thickness not more than 13 millimeter. The LV cavity is quite dilatation. And importantly, if the patient stop to exercise or stop to play in sport, the thickness will be decreased or reconditioning. And of course, the patient should at least professional or competitive level of sport that can explain the cause of athlete heart. And how to differentiate between hypertensive heart disease. If we favor hypertensive heart disease, the LV thickness quite less than 18 millimeter. And LV thickness can regression. The LV hypertrophy will be reduced after we control hypertension around half or 1 year. Well, back up to our case, the LV wall thickness is around 24. So above 18 millimeter, that's common in patients with hypertensive heart disease. However, this patient without LVOT gradient, and we ask for advanced imaging physician, they still confuse, they still doubt between obesity, LVH for hypertension or Hcm. So do you think what is the next step to confirm diagnosis? Yes, cardiac MRI. We did cardiac MRI show concentric LVH with small focal fibrosis at the lateral wall. Again, expert and advanced imaging guide still doubt between Hcm symmetrical type or hypertensive heart disease, and how to confirm diagnosis and management for this patient. Yes, we can do only one doctor or only one team. We need multidisciplinary heart team. Advanced cardiac imaging still doubt between Hcm symmetrical type and hypertensive heart disease. So we ask interventionist. Interventionist offer for endomyocardial biopsy. However, the patient afraid and he denied, no, I do not do anything invasively. For now, lucky us, we have super doctor. Yes, genetic counselor and testing. Actually, he was the pediatric that expert in genetic. He sent the blood test for cardiomyopathy, multi-gene panel testing. And this patient negative for sarcomere mutation for hypertrophic cardiomyopathy, like myosin heavy chain and troponin T. Dr. Juang will discuss this point again. So our decision was made to treat this patient with HEP and hypertensive heart disease. We plan to follow up cardiac MRI after control hypertension, control sleep apnea by CPAP, and weight reduction. And we plan to bariatric surgery for this patient if it fails. Let me start with the second case, Mr. Giant Heart. And 46-year-old man present with palpitation and syncope. And again, negative for sudden cardiac death or history of heart disease on family member. On examination, which is common, show sustained double orbital impulse and systolic ejection murmur, which is dynamic increasing when using maneuver like standing and Valsalva. And EKG for this patient, you can see the very LV hypertrophy on EKG. And echo. This is a typical case of hypertrophic cardiomyopathy. Show asymmetrical LV hypertrophy. Maximum thickness is 25. And we use the short axis show systolic anterior motion of mitral valve or SAM. We did the color exam, show moderate MR from SAM mediated. And the gradient at rest on supine position. This is at rest and on supine position. The gradient is 101 millimeter mercury, which is very high gradient. Therefore, the diagnosis of this patient is symptomatic, very severe obstructive hypertrophic cardiomyopathy with moderate MR from SAM. The treatment aim for this patient is number one, yes, symptomatic relief for the LVOT obstruction. And importantly, prevention of sudden death for this patient. For this patient, regarding the new ACC guideline for Hcm 2020, AICD for primary prevention if the patient have at least one major risk factor, such as family history, massive LVH, and at least one episode of syncope that is likely from arrhythmia. And the new criteria is LV apical aneurysm any side and ejection fraction less than 50%. And do not forget, if cardiac MRI show the extensive scar, at least 15% of LV mass or non-sustained VT on ambulatory monitoring, the AICD may be considered as a class 2B indication. Yes, our case has a high risk for sudden death. We put the AICD in. You can see the lead of AICD. For the symptomatic, we start with verapamil. And patient still symptomatic and LVOT gradient at rest is around 86, which is above 50 millimeter mercury. This is a failed medication, and we plan to use septal reduction therapy for myectomy with mitral valve repair for this patient. So the pattern of disease progression of Hcm, around 80% have the stable phenotype, and around 15 to 20% have adverse remodeling, and some patients have over dysfunction to heart failure. So the HCM phenotype is quite complex beyond left ventricular hypertrophy. For now, the current Hcm treatment is the lifestyle modification, family screening, pharmacological treatment, septal reduction therapy. And for now, we have more data about transcatheter ablation of atrial fibrillation, and some more studies show that can prevent the adverse remodeling, AICD for sudden death, and advanced heart failure, including heart transplantation in patients with reverse to the end-stage heart failure. So in patient with Hcm and heart failure, please note that in the absence of LVOT obstruction, if ejection fraction less than 50%, we should start guideline-directed medical therapy, as in patient with reduced ejection fraction. And do not forget work up the cause, especially the coronary artery disease, and stop discontinue negative inotropic agents such as verapamil and disopyramide. And importantly, if the ejection fraction less than 50%, AICD is reasonable for prevention of sudden death. Well, this is the case report from circulation heart failure. The young man with non-obstructive HCM and progression to advanced heart failure requiring heart transplantation. In this point, it is still an unmet clinical need. How we can prevent like this case, prevent the progression of heart failure. I think for now, the emerging evidence regarding to myosin modulator. In the myosin stimulator, like omecamtiv, which is positive trial in DCM and patient with reduced ejection fraction. In contrast, myosin inhibitor, mavacamten, which is positive trial in patient with Hcm, and with quite more data in patient with preserved ejection fraction. That professor mentioned previously in Explorer HCM that did in patient with Hcm with the LVOT gradient above 50, New York Heart Class 2 or 3. You can see in patient receive mavacamten can reduce the LVOT gradient at rest and at Valsalva. And the benefit is very fast, within 4 weeks. I think it's very interesting. The important point is around 60% have complete relief obstruction, the LVOT gradient less than 30. And interestingly, around 27% had complete response. I mean, asymptomatic and LVOT gradient less than 30. So I think for this study, I call Explorer HCM phenotype I mean the patient is the same inclusion criteria in Explorer HCM trial. I will call Explorer HCM phenotype, which is same as the previous our case. The use of mavacamten can relieve the symptom and relieve the gradient that look like a non-invasive or medication septal reduction therapy, and we can prevent to surgical or alcoholic septal ablation. In the future, I think if we have more data, how to early treatment, and is it can reduction of sudden death the risk, and is it can prevent the adverse remodeling in patient with obstructive Hcm. I think we waiting for the we should waiting for the more clinical data and more clinical study. Well, this is my conclusion. HCM is the complex genetic heart disease. For now, we have the emerging data like a molecular approach for the specific pathological mechanism of Hcm, and we'll change the treatment in the tailored perspective, like mavacamten, which is a myosin ATPase inhibitor, can relieve the symptom and relieve the LVOT gradient. In the future, the early treatment with mavacamten can reduce the sudden death or can prevent the adverse remodeling. I think we should waiting for the future clinical study. And do not forget to risk stratification of sudden death. The cardiac MRI is the important role. Screening for the first degree relative and counseling for exercise in patients with hypertrophic cardiomyopathy. And you can see we can treat the patient with Hcm by one-man show or by one doctor or by one team. We need a multidisciplinary team to make the decision and treatment the patient with Hcm as the tailored treatment. Thank you for your attention. ขอบคุณครับ
Thank you. Very nice. I would love to revisit Thailand. Okay, thank you. Any questions from any participant here? Well, I haven't received any question raised on the in the Zoom. Let me ask a question. You have given us very nicely two cases which are very important and very nicely lay out how to approach them stepwise. Let me just give you two probably common scenario, okay? Just ask you how you're going to manage this. Quite often, patients with hypertrophic cardiomyopathy, they have atrial and ventricular arrhythmia. We're talking about sudden cardiac death, all related to ventricular arrhythmia. But very few people talk about atrial fibrillation, atrial tachyarrhythmia, which is also quite common in hypertrophic cardiomyopathy. So let me ask you, there's a patient here with hypertrophic cardiomyopathy with symptomatic atrial fibrillation. Paroxysmal, every time paroxysmal gets symptom very severely, so you know it's very poorly tolerant to atrial fibrillation in hypertrophic heart. So how do you approach this patient with atrial fib? Well, try with the medication, fail. Continue to break through.
Thank you for your question. Very short answer is I will consult the expert for EP electrophysiologist. So I think I will work up the secondary cause first, such as hyperthyroid disease or other condition that can precipitate the atrial fibrillation get worse. Second, I will start the anticoagulant for prevent embolic stroke. And I think if the patient have severe symptom, I will look for the echo and the cardiac MRI to looking at that the patient have the other condition or other pathological that we concern, such as a lot of scar in the left ventricle, something. And I will ask the electrophysiologist to consider ablation of the atrial fibrillation.
You do, despite the fact the patient has a thickened heart. The recurrence rate of ablation, Atrial after ablation is high. So this part is still controversial though, okay? It's again depends on severity Atrial, and if you really fail to control the rhythm, which is a target for Atrial with the hypertrophic heart, but sometimes it's extremely difficult to have a rhythm control. Now, ablation is one option, but I think it's got to be very careful. I have to tell patients very, I mean, just like opinion share, something like that with the patient family, that tell them that this recurrence is very high, even though initially you got all PVI, but it's not enough because they got a pathological heart. So it's the recurrence rate is high, and at this time, it's not recommended for ablation, for catheter ablation, for Atrial in the hypertrophic heart, due to the fact that the recurrence rate is very high. So I wish there will be a better way, but I'm sure it's still coming that even with hypertrophic heart, one can do catheter ablation with a limited approach, and hopefully it can really help, but not for long term. It's just for short term control, perhaps. The long term is extremely hard. So thank you for asking. I think anticoagulation is a very important issue, right? Regardless of what the score system, don't use a point score, and that people always calculate with Atrial. Now, with patient with hypertrophic heart, regardless score is 0 or 1 or 5, you go ahead anticoagulation, right?
Yes.
So, all right. Now, second patient scenario will be the patient who is pregnant. How are you going to approach this patient?
In pregnancy, right?
Pregnant lady with a hypertrophic heart.
Yeah.
Symptomatic.
At the same, we're looking at the risk stratification for the Hcm patient. The important thing is look for the LVOT obstruction. Is the patient have the LVOT gradient or obstruction? If the patient have LVOT obstruction, if it's severe or not respond to medication, we should ask the team like OBGYN, OBGYN doctor and our heart team to make the decision about the LVOT obstruction. Since in the pregnancy woman, if she had the severe LVOT obstruction, which is a high risk for pregnancy, I think the team depend on the team, depend on the patient and her family. Yeah.
Do you give them, what kind of medication would you give to them with a pregnant woman? What kind of medication would you prefer to give the patient with obstructive heart?
I think the safe medicine depend on the trimester of pregnancy too, but the safe medication I think is beta blocker is okay.
Beta blocker, okay, probably safest, right? I agree.
Yeah, for pregnancy.
All right. Well, other speaker and Professor Juang, do you have any comments on those two questions I raised, or you may have other questions about it?
Yeah, I'd like to echo the Professor Huang's mentioned about the atrial fibrillation in patients with hypertrophic cardiomyopathy, because the prevalence is very high, it's up to 27%.
Right.
So in patients, so this is a very specific group of patients. So even the prevalence much higher than other populations. So the guidelines suggest us to treat them. Anticoag is very important. So because some patients they die because of stroke. So HCM patients died of 3 reasons: stroke, heart failure, and VTVF, sudden cardiac death. So stroke prevention in patients with hypertrophic cardiomyopathy is very important. And I think I will ask the last questions for Professor Vichai about you mentioned about lifestyle education. Yes, and also some issue about exercise educations, restrictions. Could you
How about sexual activities?
That's part of exercise.
Would you allow them to have sex?
where I answer the set is low to moderate exercise. They can, but do not use the like a stimulant drug like yeah. And about exercise, if the patient is high risk for arrhythmia, it's easy to stop in high intensity exercise, kind of like a competitive sport like a soccer or like marathon runner, something we should stop it. But the patient can start like a light or moderate intensity, like walk with a dog. You mean walk with a dog, like in Chinese, like yoga.
Yeah.
Do not forget to drink the water to prevent the high gradient. And I have one patient which is a professional sport like tennis player, and he very young too and want to play tennis. He had first episode of syncope and did the AICD, and he need to play the tennis again. So this is option. We choose again multidisciplinary approach for this patient, and the exercise test like VO2 max exercise might be help to make the decision that this patient can play the sport. Yeah, which is the dilemma. Yeah.
Thank you.
So it means you are check the price, you are doing the testing, exercise testing, to measure the pressure gradient while the patient do the testing.
Yes.
So
and,
you do the stress echo, or you just treadmill or something else?
I use stress echo.
Stress echoes.
And in athlete we use to use the measure of the VO2 max on the exercise too, and use many data together and multidisciplinary team. Yeah.
Also use the bicycling.
Yes.
Bicycling?
Not treadmills.
No, I will buying like this.
Oh,
yeah.
Okay. Okay, thank you. Thank you, Professor Vichai.
All right. Well, now let me see. Anybody from the speakers, panelists, or participants, and Professor Ling? Anything else? Other than that, I will leave to Dr. Juang for conclusion. The closure remark.
Okay. So I think this is a very great session, and we would like to thank the Pacific Society of Cardiology, APSC, for help to build up this cloud education program. So this cloud program really bring people in the Asia together, especially in the pandemic area. Nobody can go out to join the international meeting at this moment. So we are looking forward to this kind of meeting in the future, and we thank all the participants, all speakers, all chairmen for today's talk, for their excellent contribution to this Asia Pacific Society. Thank you.
Thank you all. Thank you for the contribution.
Okay, thank you. Thank you, Vichai. Thank you, Rodney.
Bye.
Thank you, Yasushi. Yeah, right. Okay, thanks.
Bye-bye.
And